Okay, this last part, organizational systems issues, addressing tobacco dependence through organizational change. And there's a couple really good articles that I'll point you to. This one by Omodio, looking at having it be very organization-centered to engage practitioners at all levels within your organization. Having it be needs-focused to address the concerns of that particular organization. So what are the issues that are going on for your organization, and getting an assessment of what those needs are so that that'll drive your plan for change. And being flexible, so you'll want to be responsive to readiness for change at the organization level. And that it be relatively affordable. This Doug Zadonis is a psychiatrist in the field. He's now at UMass Boston. And this article in particular is really great, looking at a 12-step model for organizational change specifically to address tobacco in your system. The first step being to acknowledge the challenge of addressing tobacco. That yes, tobacco is a major issue, and it is a challenging issue to address with your clients and with your system. Otherwise, you would have done it years and years ago. He recommends establishing a tobacco leadership group, so a focus group that's going to be kind of spearheading the changes in your organization. Create a change plan, an implementation timeline with measurable goals and objectives, so you have a sense of what is this going to take and how long is it going to take and how will we know that we're meeting our goals as we go through. Start with easy system changes, for example, adding tobacco to an intake form if it's not there yet. Conduct staff training and ongoing supervision. Providing treatment for staff who smoke, that's critical, okay? If your staff members are smoking, it's going to be very hard for them to address tobacco with their clients. You know, if they're smelling like smoke, it's going to be very hard to be convincing to advise patients to quit smoking. And so, you know, at a first level, providing treatment for your staff to let them know that it's really critical for their health, for the health of the organization, that they be provided treatment for quitting. Number 7, require better tobacco assessments and chart documentation. If you're not asking the question, identifying smokers, clearly you're not going to be treating, so that's the first step. Incorporate tobacco treatment materials into patient education curriculum. So if you have groups about substance use, alcohol and drugs, making that group about alcohol, tobacco, and other drugs of abuse. Okay, getting tobacco into that language for your treatment. Providing nicotine replacement medications is excellent if you can be doing that. Patches, gum, lozenge, letting patients know that for Medicaid it's covered through the state. Integrating tobacco treatment groups into program. So you could have specific tobacco treatment groups. You could have NA, or Nicotine Anonymous, potentially come to your site to start offering groups. There, that's that one. Developing written policies addressing tobacco use. So how will tobacco use be handled? What are the rules? Can people smoke somewhere on site? Can you start to change that? How close to the door can they smoke? If there's breaks, making sure they're not called smoking breaks, have them be more like mental health breaks. And then also, how are you going to address tobacco use? Like, so if staff members do smell like smoke, or if they're smoking with clients, how is that going to be addressed? What are the policies that your organization is going to have? Here's 12 easy policy changes to better address tobacco use. This is still from the Zadonis article. Using the phrase alcohol, tobacco, and other drugs. Modifying assessment forms to include tobacco use and motivation to change. Identifying smokers in the clinical chart so that everybody on the team is aware of the issue. Getting tobacco dependence on the problem list as a diagnosed Axis 1 disorder. So again, it doesn't need to be that first diagnosis on Axis 1, but getting it on there, showing that it's significant and relevant to the work that you're doing. Providing educational materials on tobacco, and definitely your state Department of Public Health would have materials, American Cancer Society, American Lung Association, getting materials. NCI, National Cancer Institute, has some really wonderful materials that are free. There's one called New Horizons. Clearing the Air is outstanding, but right now it's out of print. But I highly, highly recommend it. It's a beautiful color brochure. It is stage-tailored. You can get it from NCI when they get that printing done, and it's free. And then the other one I think is called New Horizon, and it's for older smokers, and they definitely have those available now. Relabeling smoke breaks to just breaks. Banning sales of cigarettes. So if that's happening in your setting, not allow that to happen. I do consulting for a group in San Mateo, and they're telling me that there's still staff going out and purchasing cigarettes for patients and bringing it back. And that's not legal. You're not allowed to sell cigarettes and such unless you've got a certain license to be doing so. Not allowing staff to smoke with patients, limiting hours and places for smoking, and have it not be the most desirable place on site. When I was an undergrad in North Carolina, I used to volunteer with the Ronald McDonald House and help with kids in child care and stuff while they were at the Children's Hospital. And they had a glassed-in porch that was really beautiful, and it was the smoking room. And there was a little sign thanking, I think it was R.J. Reynolds for the donation, or Philip Morris for the donation of that. So, you know, rethinking where is it that people can smoke, and making sure that the other patients aren't being exposed. There's toolkit files for helping with organizational change, and this is a website for that. And requiring smoke-free grounds or create less visible places where smoking is permitted. You don't want all the smoking to be happening at that front door, so when patients, visitors come to visit, you know, that's the message that they get, that here's, you know, this is a place that everybody smokes, having it be much less visible. And smoking staff should not give the appearance of smoking, so not smelling of smoke. So in summarizing, smoking, looking at the barriers, we've looked at the barriers today of what's gotten in the way of addressing tobacco mental health setting. Hope you leave kind of reframing those barriers. Smoking is a clinical issue relevant to mental health treatment. Our clients are interested in quitting. Our clients can quit without threat to their mental health recovery or sobriety. Providers are interested in training, and training programs impact clinical practice. And tobacco treatment is cost-effective and can be done efficiently. Viewing yourself as a change agent, you know, you're coming today, you've put in 3 hours of your time, and seeing how is that going to change you, and how is that change going to change the organization and help the clients that you serve. Thinking about what can you do to move your system along the stages of change to support tobacco treatment for smokers with substance dependence and mental health disorders. And just wanted some acknowledgments. Karen Hudman is the originator with her group. Robin Corelli, Lisa Kroon developed RX for Change at UCSF, and then we've been adapting it, working in collaboration with Karen for psychiatry, for the field of psychiatry. Sharon Hall has been my mentor at UCSF and has done work in this area for over 30 years. And then my grant funding, the California Tobacco-Related Disease Research Program, the National Institute on Drug Abuse, National Institute on Mental Health, American Cancer Society, and then I also have recently got an investigator-initiated research award from Pfizer.